So I'm going to talk a little bit about cellular therapy, CAR Ts. Everybody's seen the commercials and the advertisements, and everybody knows that this is a very expensive therapy, but effective, especially for pediatric leukemias in children, where the cure rates are at least 50% for children. And it's also effective for adults with non-Hodgkin's lymphoma, and the long-term survival rates, at least up to 2 years, appear to be in the 40% range. These are for patients for whom other therapies have usually failed. So we all know that cancer can be caused by a variety of diverse and genetic and environmental factors, and the incidence of cancer in the hematologic malignancies, including acute leukemia, MDS, and some lymphomas, are increasing. It's felt that every day we're developing cancer cells, but these are usually caught by our immune system and destroyed. And mostly the T cells, the T immune cells, and the NK cells in our bodies are able to do this. Cancer develops when one of the tumor cells or malignant cells develops, but our immune system does not recognize it as being foreign and doesn't take it out, if you will. So we essentially become what we call allergic to the cancer. Normally, for normal immunity, you need a target. And so on these tumor cells that might spontaneously develop in our bodies, they have unusual targets on their surface that are recognized by the immune system and are destroyed. This is called an antigen. It's usually on the surface of the cell, and again, our T cells and B cells recognize these antigens as being foreign and will destroy them. Antigens can be targeted by antibodies, and that's rituximab, as you know, for lymphomas and leukemias. These are made by B cells or by T and NK cells, which are cells that directly attack tumor cells, or in fact by both mechanisms simultaneously. For cancer, the T immune cells do most of the work in preventing and eliminating disease. These are the cells that we administer when we do an allogeneic bone marrow transplant. The T cells are the ones that are the, if you will, the business cells of eliminating and preventing leukemias and lymphomas from coming back. The use of immune cell therapy is not new. Allogeneic bone marrow transplant, as again mentioned, is basically an immune therapy. The target is cancer antigens on our malignant cells. Some of them we know, some of them we don't know. And when we put a new immune system into your bodies, these new immune cells are able to target the malignant cells and take them out. Antibodies also can be used. Rituximab, which targets CD20, brentuximab, which targets CD30 and is used in Hodgkin's disease, are effective antibodies that we can give pharmacologic doses to and destroy these malignant cells along with normal cells that carry these antibodies. Vaccines can be used and are very effective in mostly preventing cancer. HPV vaccines, which we give to young girls and teenagers, are effective in preventing HPV infections, which cause cervical cancer and also potentially head and neck cancer. Hepatitis B vaccines also are also effective in preventing liver cancer. These target viral antigens, and viral antigens can lead to the development of malignancies in our normal cells. Dendritic cell vaccines are also something that's been explored over the last 15 to 20 years. These target tumor cell antigens, peptides or RNA, and are been shown to be effective in tumors as diverse as ovarian cancer, and we have an ongoing program in that disease, and even in brain tumor malignancies. And finally, engineered T cells and chimeric antigen receptor T cells. These are two groups of T cells that we now engineer in the laboratory, and they target specific tumor antigens on the surface or inside the cell. And in particular, the CAR T cells that are FDA approved are targeting CD19, an antigen, again, a foreign protein, or actually in this case, a normal protein seen on B cells of acute lymphoid leukemia or non-Hodgkin's lymphoma. So T cells kill cancer by recognizing these abnormal cells. The antigen, as you can see here in the is on the cell surface of the tumor. This is taken up by a group of cells called dendritic cells. The dendritic cells then are attached to or give signals to immature cytotoxic T cells. The T cells then start to grow in our lymph nodes and in our bodies and diffusely, and these activated cytotoxic T cells go and attack tumor cells and eliminate the tumor cells as well. This is a normal phenomenon that occurs every day, and it also occurs when you get a virus infection. So this is how viruses are killed. The virus antigen is taken up by the dendritic cells in our lymph nodes, activates the T cells also in the lymph nodes. The T cells kill the virus just like it may kill cancer cells. T cells kill cancer by a direct lethal hit. And these tumor cells or viruses, etc., are attracted to the T cells by antigens and markers on our cancer cells called MHC classifications, and through a peptide on T cells. And these are attracted again by the tumor antigens. Once they are in close proximity, the T cells poke holes in the malignant cells, perforin pores, and then chemicals from the T cells, a lot of different ones, including granzymes shown here in perforin, get into the cancer cell and are able to affect a kill. So the goal of these new therapies is to get these T cells close by or attaching to the cancer cells, which again, for a variety of mechanisms, doesn't happen. In fact, in cancer, tumor cells are not recognized as being formal as non-self, and that's called anergy. So in this top cartoon here, the dendritic cells we already talked about, the tumor antigen activates the T cells. The T cells get activated and kill the tumor cells. But in cancer, this anergy develops in which the antigens may be on the cell surface of the dendritic cells. The dendritic cells may be defective, or the antigens may not attach to that. So they don't activate the T cells, and the unresponsive T cells just kind of float by the tumor cells and don't do their job in killing the cancer cells. After a cancer starts to grow, it's really a traffic jam of inhibition of a normal immune system. Not only can't these cells attach, you develop cells, populations, including regulatory T cells and macrophage cells that inhibit the immune response. There's also a milieu of soluble immune factors, and all of these basically, once the cancer starts growing and getting bigger, secreted by the tumor cells and really just knock off the immune system. So in order to overcome all of these, basically we do transplants which wipe out all of these tumor cells and all of these abnormal cytokines and regulatory T cells and do that. So the question was, can we do something in addition to transplant that might actually be effective in eliminating the disease? And one of the ways that we can fix the immune system, one of 6 or at least 6 mechanisms, is to re-educate T cells directly into being able to recognize and kill tumor cells. I liken it to a key and a lock. So your tumor cell is a lock, your T cell is a key. If the key fits in the lock, you'll get the tumor cells to die. And what happens in many of the cases, the key doesn't fit the lock or the key is not there, and so the lock doesn't get turned and the cancer cells don't die. 2 ways of engineering T cells to put a lock and a key together, in other words, to put a key on a T cell, which are not normally there, are the use of T cell receptors, which we are doing currently at our place for melanoma and for renal cell cancer with the National Heart, Lung, and Blood Institute, or chimeric antigen receptor cells, which again put the key, and the key for lymphoma and leukemia is the CD19 key fits into the tumor cell, which has a receptor for CD19. And T cells normally don't have these keys on the cell surface. So you can genetically alter T cells, put a key on them, the key then attaches to the tumor cells in the lock and then ends up killing the cells. So here is a cartoon showing the CAR T cells here with this nasty looking tumor cells, and there is attachment through leukemia and non-Hodgkin's lymphoma through a CD19 on the B cells. The B cells then which are the malignant cells here, have the CD19, and the lock and key are attached through the antibodies on the cell surface of the CAR T and the tumor cells. So what we do again is take normal T cells and engineer them, if you will, using viral vectors to now produce on their cell surface the key that ends up in the lock on the tumor cells. What happens again is we collect cells through a process called apheresis, which is how patients receive platelet transfusions most days. We get these cells through an apheresis process. We can collect normal lymphocytes. These then are taken to the laboratory where viruses will insert the antibody receptor on the cell surface, and then these are infused into patients after a period of 2 to 3 weeks. So in cancer, the immune cells are dysfunctional, especially the T cells. They simply cannot be activated normally to kill cancer cells. They are inert, or they're just too few and just do not recognize the cancer cell as foreign. With CAR T cells, we re-engineer T cells to kill cancer cells by directly putting on their cell surface a receptor for the tumor antigens. This receptor acts like a magnet to the tumor cells, and with direct contact, the T cells can now effectively kill the cancer cells. CAR T cells are effective in acute lymphoid leukemia, as you heard about, non-Hodgkin's lymphoma, and chronic lymphocytic leukemia, and they are FDA approved for pediatric acute lymphoid leukemia and diffuse large B-cell non-Hodgkin's lymphoma that's relapsed after 2 or more prior therapies. They're not FDA approved yet for CLL, although they have been shown to be effective in this disease. In fact, one of the earliest benefits were in patients with CLL. But as Dr. Vinu showed you, we have so many effective therapies for patients with CLL, and they're doing so well with some of these novel therapies that the call for patients who fail all these therapies is low, and so it's been a low priority for the companies developing these new therapies. There are 2 FDA-approved CAR T products, Kymira, which is from Kite Gilead, and Yescarta, which is FDA approved through Novartis. And again, these are both approved for refractory large B-cell lymphoma and acute lymphoid leukemia. Here's the picture of the first young girl that got CAR T cells from herself. These were engineered in the laboratory, and you can see here that this is not a huge bag of cells. It's given through a syringe. This is a lady who was about 9 years old at the time, had failed all sorts of therapy, including allogeneic transplant, and got this at the University of Pennsylvania under the direction of Carl June and colleagues. And here's a picture of her 5 years later, alive, healthy, and cured of her leukemia. So a very effective therapy, especially in pediatric ALL. So here's the NCI experience, again showing long-term remissions. These are patients with MRD negative disease, and these are the long-term survival. Approximately half of these children, again, who failed all these other therapies are now cured of this, and this is effective therapy, and again, FDA approved. Here's additional data. This is refractory patients with acute lymphoid leukemia, again, showing approximately a 70 to 80% long-term survival rate. It does work in non-Hodgkin's lymphoma. This is some of the first data from the National Cancer Institute. Kite in-licensed the technology from the NCI, and you can see here a patient with non-Hodgkin's lymphoma who got, again, the same CAR T cells made from their own blood, showing large globs of tumor in the liver on a PET scan, and after therapy, a complete remission. And about 40% of patients do well long-term. So in the B-ALL, again, 90% complete response rates and about 50 to 70% long-term remissions. And non-Hodgkin's lymphoma, again, 6 months complete remission rates, about 30 to 50%, depending on the subtype of disease. And overall, again, about 40% of patients are doing well long-term at 2 years. Again, these patients would normally have at best a 10 to 20% long-term survival with other non-immune or immune therapies, including allogeneic transplant. Here's the data that we just published a few months ago showing that remissions are sustained once you enter a complete remission with this therapy. Follow-up at 1 year and 2 years is identical, and we're expecting that these patients will continue to do well long-term. So we do think that these patients are being cured. Here's the data in CLL, again showing a large mantle of lymph node abnormalities. And again, after the therapy is given, this huge mantle of abnormal lymphoid cells are completely gone. It is, again, effective therapy, but not FDA approved for this indication. And you can see that these cells that Venu showed you totally disappear from the bloodstream. And this is, again, 5+ years after the initial infusion of these cells. So the effectiveness of an allogeneic transplant is largely based on its immunotherapy effects. Attempts at duplicating the immune effects in a non-transplant setting are showing promising results for hematologic malignancies, with the first licensed products for acute lymphoid leukemia and non-Hodgkin's lymphoma available since late 2017. The cost of these, as many of you know, are very high. They're in the range of $350,000 to $400,000 just for the product itself. That doesn't include the hospital stays, and those can be significant as well. The main toxicities of these cells, you don't get anything for nothing around here. The two toxicities are cytokine release syndrome. This is systemic inflammation associated with T cell activation and growth. These range from mild and self-limiting with fevers and muscle aches to severe and life-threatening in approximately a third of the patients. This includes low blood pressure, requiring blood pressure-sustaining medication, breathing difficulties with low oxygen levels and occasionally needing to go on a ventilator, and kidney damage, including acute kidney failure, that all of these are usually reversible, yet these patients do require ICU care and a team of doctors that's available 24/7, not just somebody who's going to come and visit you for a few minutes once a day or so. The other major toxicity is neurotoxicity. There are the possibility of getting these cells into the CNS or cytokines associated with these cells having an effect on the brain, and confusion, speaking problems, delirium, hallucinations, semi-coma, or even coma can develop. This occurs in approximately 25% of patients. These, again, are usually reversible over a few days to weeks, but very rarely brain swelling can be life-threatening and has been. So again, these are not treatments for the faint of heart, yet at the same time, because of these toxicities, many of us are looking at ways of maintaining the effectiveness of CAR T cell therapies with less toxicity, and there's been some recent data to suggest that this might be happening. The other toxicity of CAR T cells are financial. That certainly is a toxicity. Costs about $350 to $375. Medicare is deciding on how they will handle these expenses. Medicare pays outpatient, will reimburse you for the drug itself. On the inpatient side, Medicare pays as a bundled process. For high-cost things, they'll cover half of the expenses associated with the drug. So if it's $400,000, they're offering $200,000, although I did see an email yesterday that maybe they'll give 2/3 of the cost. That's still a substantial amount of money for a single patient, and hospitals obviously are balking at doing this. We'd like to do these outpatients so that patients don't have as much in the way of expenses, and we're able to treat more patients. The combined, however, because of the toxicities that I talked about, the total care is at least $1 million per patient. But again, you're dealing with a cost, but at the other end of the spectrum, you have a patient who has failed multiple therapies, and in many cases, the really only true option is a hospice. So 40% of refractory non-Hodgkin's lymphoma, a 2-year survival without relapse. It's hard to say no to a patient based on just a financial issue as well. And we are, as societies with the National Marrow Donor Program, are working on trying to convince Medicare as well as other payers to be a little bit more liberal. At the same time, we're working with the companies, and again, another email came out yesterday that one of the companies may be interested in reducing the cost if there could be more guarantees for patients getting this therapy. So I think over the next 6 months, we're going to see maybe a clearing of the storm and perhaps a little bit an ease, so allow more patients to be treated. Fortunately, there are still clinical trials ongoing, so many of the patients, including those in the Chicago area, can get this therapy without the $375,000 charge because, again, the investigational products are covered as part of the clinical trials. Before I finish, I do want to talk about multiple myeloma. Dr. Hagen did mention this. This was published just a week or so ago in the New England Journal. This was the first study on a BCMA CAR, which is a tumor antigen unique to multiple myeloma cells. They developed a CAR to this, and a 33-patient study by Bluebird Pharmaceuticals. These are patients with refractory disease. They'd failed 3 lines of therapy. They still get the cytokine release syndrome, 3/4 of the patients. Neurotoxicity a little bit higher than normally seen at 42%, but these are usually mild. 85% of the patients went into remission. 40% of the patients went into complete responses, but unfortunately, many patients still relapse. The median response is about 11.5 months. And while I showed you the curves where everything was pretty flat for the non-Hodgkin's lymphoma, this still seems not to have a tail on the curve. This is not totally surprising to me because we do allotransplants in lymphoma and cure about 30 to 40% of patients. We do allotransplants for relapsed refractory multiple myeloma, and essentially nobody is cured. So immune therapies for myeloma, like CAR Ts, may be more of value in the early treated patients that are high risk. And studies are planned and are being developed to look at this and will be available in early 2020. So what's the future? I think you're going to see more targets, more diseases. Off-the-shelf CAR Ts are going to be available in which we can do donor CARs and strip out the part of the T cell that recognizes your cells as being foreign. So we're going to get you the business act of the CARs and killing the tumor cells without the allogeneic or the difference in the immune between you and your CARs. So we'll be able to say, I have a patient with lymphoma, and I want to do CAR Ts. You'll call them up, they'll send you the cells, and you'll be able to treat the patient within a week or so. The other thing, again, is development of a universal CAR. We actually have this trial ongoing currently at our institution. This is a CAR that attaches to antibodies. So we talked about the lock and the key. This is like a sandwich. So you have the tumor cell, one side of the bread. You have an antibody that you put into the patient, in our case, rituximab. And then the other side of the bread is the CAR T that recognizes the antibody. So the CAR T, rather than directly attaching to the tumor cell, attaches to an antibody, and the antibody can be any antibody, and they're doing this in actually breast cancer. The antibody attaches to the tumor cell, the CAR T attaches to the antibody, and we are seeing responses in this unique type of CAR T. So again, off the shelf, potentially available to treat not just lymphomas, not just leukemias, but breast cancer and Hodgkin's disease and multiple myeloma. As was mentioned, we are, with the Leukemia Research Foundation, developing a CAR T program at our institution. We have the facility on site. The McCormick Tribune Foundation gave us money a few years ago to establish a cellular therapy processing laboratory, and we're able to make CAR T cells ourselves. We have a queue or a clue of developing a CAR Ts, which are designed to be as effective but reduce the cytokine release and neurotoxicity. This is pending FDA approval. We've got the CARs; they're all ready to go. We're in the process of submitting our final approval to the FDA, and these will be available at our institution, and we are offering them to other academic centers in Chicago once we're up and going. So, and again, one of the nice things about this, at least from our perspective, is that the costs are going to be covered by the clinical trial. So I'm going to stop there, and let's keep moving and have our next speaker talk. And again, we'll be able to answer any questions you have on this specific topic in the question and answer period.